Hello, everyone. This is Dr. Daneshmand from San Diego Fertility Center, and welcome to our webinar. I'm just going to wait about 2 minutes right now in order for everyone to join us, and then I'll come right back to you. Thank you. Hello, everyone. This is Dr. Daneshmand from San Diego Fertility Center. Welcome to our webinar tonight. Tonight, what we wanted to do is address some of the concerns that you have in regards to fertility, pregnancy, and the current COVID-19 pandemic. But also what we wanted to do is go over the overall fertility workup in regards to diagnostic testing, treatment, and then really subsequently open up the webinar to all of your questions and in order to address all of your concerns and questions. So what I wanted to do is, first of all, introduce myself. I'm Dr. Daneshmand. I've been in practice for about 21 years. I did my residency and fellowship training at UCLA. And over the course of the last 21 years, we have all been involved in research and publications. Our research has focused in on IVF topics and areas such as endometrial receptivity, the classification of embryos and the grading of embryos, and how we correlate that to a successful IVF cycle, an implantation, and a healthy pregnancy. And our latest research, which is actually based on a research grant that we recently won, is for non-invasive screening of embryos, meaning that at this particular point, we perform biopsies on embryos in order to determine chromosomal normality and determine the presence of abnormalities such as Down syndrome. But we're developing the latest techniques of analyzing the DNA of the culture fluid where the embryo grows. And through the analysis of that DNA, we can determine the presence of any genetic or chromosomal abnormalities that can be sequenced. So a little bit of background in regards to our research. Now what I wanted to do is give you an update on the latest studies in regards to COVID-19 and pregnancy. A recent study that was published in the British medical journal Lancet had followed pregnant patients who at Wuhan University who presented with severe symptoms of COVID-19, including pneumonia. And what they did was, in that particular study, is they looked at for the presence of the virus in the amniotic fluid, in cord blood, and in nasal and oral swabs of the newborns. They found no evidence of the virus in any of those samples, and their conclusions were that there was no evidence of vertical transmission, meaning transmission from the mother to the fetus through the placenta during the third trimester of pregnancy. A recent report from Northwestern University looked at patients who were pregnant, and what that particular study found was that pregnant patients were no more prone to have severe symptoms of a COVID-19. They were just at risk as the general population, but no more higher risk. The other studies that have been done are currently continuing. There are now clinical trials looking at the latest antiviral medication called remdesivir, which is being used now for patients, non-pregnant patients and pregnant patients in clinical trials to determine its efficacy and how effective it is in treating the COVID-19 symptoms. In a recent report out of the University of Chicago, out of 133 patients who were enrolled and who were admitted to the hospital with severe symptoms of COVID-19 and pneumonia, the use of remdesivir led to a rapid decline in fever and an improvement in respiration. All the patients were taken off the ventilator, and out of the 133 patients, 125 have already been discharged. So at least in that particular study, there was a rapid response to the medication, and this makes us very optimistic that this particular medication may be used for the treatment of severe symptoms of COVID-19. Now, of course, we are following the latest studies on COVID-19, latest publications, and we'll update you as they come in and as they're published. The other factor is that with the creation of embryos, there's no evidence for this virus, as well as for other viruses, of transmission of this virus via sperm, eggs, or embryos to the pregnancy. With our stringent sperm wash and egg wash techniques, there's never been a case of a transmission of a virus, a coronavirus, a rhinovirus, hepatitis virus, and other viruses. There are many corollaries in this regard of the transmission of virus via IVF. It's for that reason that, and given the stable situation in California, that we have decided to resume IVF operations and for creation of embryos. We are currently on pause for embryo transfers, but we are monitoring the situation very carefully, and we may resume IVF embryo transfers soon, as soon as possibly June. So just wanted to give you an update in regards to San Diego Fertility Center. We have also implemented very strict sanitizing protocols and screening protocols for the office. Every team member here is wearing masks and gloves, and we are abiding by as much of the physical distancing guidelines of the CDC as possible, limiting the number of patients in the office at any given time, and limiting the number of team members, and having team members work in different teams, again, in order to minimize any risk of infection or exposure for our patients and for our team members. So just a little bit of an update on San Diego Fertility Center, and also the latest research studies that have been published and presented in regards to COVID-19. And what I'd like to do now is give the floor to my partners, Dr. Friedman and Dr. Park.
Hello, everyone. Hi, I'm Dr. Brooke Friedman. Thanks for joining us. And I just want to start by acknowledging that this is Infertility Awareness Week. So it's an opportune time for us to be talking about fertility, infertility treatment. And we just want to acknowledge that we know that this is a very difficult time for many of you who may be struggling with infertility, who may be at the beginning of your journey. You may have your infertility treatment be on pause, and we want to acknowledge that we know this is a difficult time and we're here for you. We know that infertility itself can be isolating, so particularly when we're all isolating and sheltering in place, for the most part, we know it can be particularly difficult. And we wanted to get this opportunity to reach out to you, to answer your questions, and to let you know that we're here. We're here to answer your questions, and we're here to help support you in moving forward and taking those next steps. So we're going to be talking a little bit about fertility options and infertility. And when we think about infertility, sometimes we're thinking or speaking about the inability to conceive within a heterosexual relationship over a 12-month period of time. I also wanted to acknowledge that we absolutely recognize and support there's a lot of different kinds of family building. So it may be in a same-sex relationship, an opposite-sex relationship, a single man, a single woman. There's a lot of paths forward to building a family. And we're here to help support you in finding what is the best treatment path for you. So with that in mind, I'm going to share some slides here with you. So I wanted to talk for a moment about how you're not alone. So clearly infertility can be an isolating experience, but it's really important to recognize that it affects 1 out of every 8 couples. That's a pretty staggering statistic. So if you are in this category of struggling with infertility, please know that you're not alone, and there are many effective treatments to moving forward and building your family. So when does it make sense to see a fertility specialist? So Professional organizations have recommended that for women under the age of 35, if you've been trying to conceive for over a year, it's really time to see a fertility specialist. And that's because the definition of infertility is the inability to achieve a pregnancy within that period of time, or a year. Professional organizations like ASRM, American Society for Reproductive Medicine, recommend that if a woman is over 35 and they've been trying for over 6 months, it's time to see a fertility specialist. Not necessarily to embark on treatment. That's a very personalized decision, but at least get that initial workup done. Knowledge is power. It's really important to gather those diagnostic tools, get those puzzle pieces together to really help you decide what those best next steps are and to help create the best personalized treatment plan with you and your physician. For women over the age of 40, it's recommended to seek more immediate evaluation because unfortunately time's not on our side. And this is a theme that we'll repeat a little bit throughout this talk, but unfortunately our biology as women is unfair, and we're born with our eggs and we lose them over time. And the eggs that we're born with accumulate genetic mutations as we age. So unfortunately, what that means is that time is really of the essence in terms of trying to move forward to achieve the best possible success rate. So what needs to be tested? If a couple is struggling with infertility, it's important to test the eggs of a woman as far as the egg supply, to test the sperm. We can't forget about the sperm, to look at the uterus, and to look at the fallopian tubes as well. And I'm going to talk briefly about how we do that. To assess egg quantity, we have blood tests and we have ultrasounds. It's important to note that unfortunately we don't have biomarkers for egg quality, but the markers that we have really pertain more to egg quantity, and there can be blood tests done on the 3rd day of a woman's period, such as FSH. There's a hormone called AMH that can be checked any cycle day, and these markers give us an idea of egg supply. We do an ultrasound, and there's a picture on the slide of what an ovary looks like with those small fluid-filled circles, those black dots in the middle. Those is what we call the antral follicle count. And those things combined can allow your physician to counsel you to say, well, what is my egg supply relative to other women my age? In order to know if the fallopian tubes are open, we recommend what's called a hysterosalpingogram, or an HSG, and that's a test done in radiology where dye is placed in the uterus and an X-ray is taken to make sure the fallopian tubes are open. To look at the uterus, primarily we use ultrasound. We can also do a more detailed study called a saline sonogram, where we place water inside the uterus to look at the inside of the uterine cavity and be sure there's no abnormalities such as polyps or fibroids. And a semen analysis. A very important criteria of the evaluation is to check a semen analysis. We can provide a specimen cup, and this can be collected in the privacy of your own home and then dropped off at our center for analysis. A very detailed report is created, and then this can be emailed to you. So that really is what comprises the majority of our evaluation for the basic puzzle pieces of an infertility workup. And I'm going to turn it over to Dr. Park, who is going to talk a little bit more about treatment options and next steps.
Thank you, Dr. Friedman. Hi, everybody. Thank you so much for joining us. I'm Dr. Susanna Park, and I really hope that during this time of COVID that you and all your loved ones, no matter where they live, are healthy and are safe. So I grew up in New York. I'm a former New Yorker, and that's actually where my whole family is. And thankfully, they're all safe thus far. So I really hope that your family is safe as well. So I've been in practice 17 years, and I wanted to share with you some of the fertility treatment options that are available. So before launching into fertility options, I just wanted to clarify that right now, the way most couples are trying to get pregnant would be that the egg is coming out of the ovary. The sperm is placed in the vagina during intercourse. The sperm swims up the uterus through the fallopian tubes to meet the egg at the very end of the fallopian tube. The egg and the sperm, once they meet there, we call a fertilized egg an embryo. the embryo makes its way back through the tube. That takes about 5 to 6 days, and then it sticks in the uterus. And then is when you have a positive pregnancy test. So keeping that in mind as the reference, I'd like to talk about 2 different options. One is IUI, and the other one is IVF. So let's start with IUI, which stands for intrauterine insemination. Many people in the community know it as artificial insemination or the turkey baster method. It's all the same thing. So in order to do IUI, there are 2 ways to start. The first one is no fertility drugs. If you have regular cycles and you don't really want to ovulate more than 1 egg at a time, this is a great option, meaning that we work with the rhythm of your body and we plan the IUI at that time. Versus, you may want to take fertility drugs, but why? Well, if you ovulate more than 1 egg at a time, then let's say there are 2 or 3, then you have a greater probability that the sperm and the egg may meet because there's more than 1 target for the sperm to find. So these fertility drugs come in 2 forms. One is pills, and the most common pill that most people know is called Clomid. But another drug that's gained a lot of popularity is called Femara, also known as letrozole, which, by the way, is not FDA approved for fertility use, but we use it often. It's just as effective as Clomid. So when we use it, it's called off-label use. And then there are fertility drugs in the form of injections, and they're just more potent than the pills, meaning that they usually result in more eggs being ovulated. So regardless of whether you use no drugs or you do use fertility drugs, we will monitor you with ultrasound. And when your follicle or follicles look ready, we then give you a drug to ovulate, and it's usually Ovidrel. And then we time the IUI to the ovulation. So the day of the IUI, the sperm, again, produced in the privacy of your home, is brought into our clinic, we wash it, we concentrate it, and we place it inside the uterus. So here's a photo of the uterus. This is the vagina. These are the fallopian tubes. And here are the ovaries. So the catheter is placed into the uterus and the sperm is released here. Your eggs are at the end of the fallopian tube. So the sperm will then swim through the tube all the way to the end to meet the egg here. And once they meet, the fertilized egg called embryo reverses its direction and sticks in the uterus. And once it implants, you have a positive pregnancy test. So the advantages of an IUI are, number 1, there's no surgery. The catheter that we use for the IUI is incredibly small. It takes a few minutes to do the IUI. You rest for a bit, and then you go back to work. It increases the number of sperm that enters your uterus, and it's very affordable. The disadvantage of the IUI is that fertility drugs have the risk of multiples. So if you're going to take Clomid or the fertility injections, you have to be prepared for the possibility you may have more than 1 child. And if the IUI comes out negative, it's hard to tell where things went wrong. It's possible the sperm never found the egg, or maybe it did find the egg, but it didn't fertilize. Or perhaps it fertilized and there was an embryo, but the embryo traveled back through the tube, but it didn't stick in the uterus, but rather it went just past and came out, but you can't tell because it's microscopic. So that's where the next treatment comes in, which is the world of IVF, in vitro fertilization. And the word in vitro means outside the body. So with in vitro fertilization, we don't use pills like Clomid. We may use it in addition to the regular IVF drugs, but rarely do we use it alone. With IVF, almost all the drugs are hormone injections. And you use them for about 10 to 12 days every day to make multiple eggs grow. And then while you're taking the drugs, you get ultrasound and blood work every few days. So here is an ultrasound photo of an ovary, And these are the antral follicles that Dr. Friedman was mentioning. And notice here, there's one big follicle, and these are small. This is what ovulation without any fertility drugs looks like. In contrast, look at this ovary. Do you see how there are many, many big black circles? This is what an ovary would look like when you take the hormone injections from the IVF. Once those follicles are ready, the eggs are retrieved through the vagina. And this always gets people kind of puzzled. So again, this is the vagina, this is the uterus, fallopian tubes, and ovaries. And here they drew big circles to represent the follicles. So through vaginal ultrasound, and we need that so we could see where the needle was going, a needle is passed from the vagina straight into the ovary. It does not go through the uterus, through the fallopian tube. It's a straight shot, which makes it very easy. These retrievals are done in our office. We have a full operating room with an anesthesiologist, so you are asleep. And because the eggs are taken out through the vagina, there's no scar or abdominal incision. And the duration, it depends on how many eggs, generally about 20 to 30 minutes. But if you don't have that many eggs, it probably takes about 5 to 10 minutes. So this is a video of an antral retrieval. This is the ovary. You see the black circles? They are follicles. This is the vagina over here. And here's the needle going into the follicle. A follicle is a liquid structure and the egg is inside. So the needle goes inside a liquid structure. We step our foot in a suction machine which sucks out the liquid, and then we look for the egg inside. So every follicle gets aspirated. Okay? The same day as the egg retrieval is when we need the sperm. Now, sometimes the men can't give us fresh sperm the day of because of scheduling conflict, or perhaps he lives far away. We have a lot of patients who are not living in San Diego. We have a lot of domestic and international patients. So these men will come prior to the treatment to give us sperm to freeze. The fertilization rates are the same between fresh and frozen sperm. So let's say, for example, a man has to get deployed. He'll give us sperm before he deploys, but in no way will decrease the success rate. If he's available to give us fresh sperm the day of, that's great. If the man thinks he may have a production problem due to anxiety, which is very common, our advice would be to give sperm before the day of the retrieval to freeze it. And then you can always try to give sperm, fresh sperm, the day of the retrieval, or just use the frozen specimen. So this is the way natural fertilization occurs. You have one egg and millions of sperm surrounding the egg. But in IVF, however, we do something called ICSI, intracytoplasmic sperm injection, which means we get one egg, one sperm, and we put the sperm into the egg. So here's a picture of the egg, and we're manually putting a sperm inside, and this is the sperm. So here's a video of actual ICSI performed by our IVF lab director. All of this is moving sperm. So we cut the tail of the sperm to make it immobile. We grab the sperm. And this is performed by highly skilled embryologists. So this is the egg. Notice the difference in size between the sperm and the egg. It's tremendous. This is a pipette to hold the egg in place. This is the pipette with the sperm. You poke the egg. Throw back some media, some liquid media. And there's the sperm. The skill set required to do this well is tremendous. And many times, understandably, people feel that, my goodness, IVF is very expensive, and indeed it is. But the amount of skill level it takes, the amount of people it takes, the amount of equipment to have a highly successful IVF lab is tremendous. So ICSI is done on every single egg that's mature. A fertilized egg, which we call an embryo, is then grown in the lab for 5 to 6 days. But why? Well, remember, in the fallopian tube, naturally, when the sperm and the egg meet at the very end of the tube, it takes 5 to 6 days for it to travel through the tube towards the uterus. And during that time, the embryo divides such that it goes from a 2-cell, 4-cell, 8-cell, and by the time it's 5 or 6 days old, it's got over 100 cells. And we call these embryos, they have a special name. They're called blastocysts. Not every embryo will survive to the blastocyst stage, but the embryos that do generally tend to be pretty high quality embryos. Now, IVF has an advantage where prior to transfer, we can do a biopsy of every embryo. So at the beginning of this webinar, Dr. Daneshmand had mentioned that we're a part of a study that we have received funding for, where we are trying to come up with a more non-invasive but equally effective method of testing the chromosomes in these embryos. Because the current method, which we call pre-implantation genetic testing, PGT, requires that we take a sample out of the embryo. And the study that Dr. Daneshmand mentioned talks about looking at the fluid around the embryo. Well, what kind of information do you garner from PGT? Well, 2 pieces of information. One, it counts the number of chromosomes in the embryo. So this is the correct number of chromosomes, 46, 23 copies from the egg source and 23 copies from the sperm source. But if you look over here, you'll notice that this chromosome has 3 copies. So this is 3 copies of 21, which is trisomy 21, which is Down syndrome. So number 1, it'll count the number of copies of chromosomes in each embryo. And number 2, it'll tell you the sex, if it's female or male. PGT is optional. You are not mandated to do as part of your IVF. Once we have the embryo, an embryo transfer is then performed, which is similar to that of an IUI, where catheter is placed into the uterus. However, this is an embryo we're putting in, not sperm. So this is a video of an embryo transfer. This is the uterus. This is the inside of the uterus, and that's the catheter. And in this, the person's wide awake. So the catheter goes into the inside. I don't know if you saw that flash right there. That's the embryo going into the uterus. Okay, right there. And that's the embryo transfer. So what are the advantages of doing IVF? IVF has a high success rate compared to all the other fertility treatments because it's your shortest time to become pregnant. IVF bypasses blocked tubes. So if you have a blocked tube, it will lower your success rate, be it through sex or IUI, but with IVF, it's a moot point. IVF will overcome the vast majority of abnormal sperm issues. IVF also lets you assess chromosome issues through pre-implantation genetic testing. IVF also allows for sex selection. IVF also minimizes the risk of multiples, and oftentimes people think of IVF about twins. While that's true, however, if you transfer only 1 embryo, your risk of multiples is incredibly small. And IVF allows for a variety of combinations of egg, sperm, and uterus. So for example, let's say you are a single female, you can use donor sperm, your own uterus. Let's say you are a female-female couple, you can use one woman's eggs and another partner's uterus. Let's say you're a male-male couple. You can use an egg donor, both of your sperm, not into the same egg, but we divide the eggs in half, and one male has his own set of eggs and the other male has his other set of eggs. We transfer it into a surrogate. Okay, if you're a single male, you can use an egg donor and a surrogate, and they're all fertilized with your sperm. Then, of course, the heterosexual couple, it could be her egg, his sperm, and then her uterus. Okay, but what are the disadvantages of IVF? Well, in order to do that egg retrieval, you need anesthesia. So it is a surgery, but it's a very mini outpatient surgery that lasts about 20 minutes. And it is the need for surgery. And finally, of course, the cost. So at this point, I'm going to turn the screen over back to Dr. Daneshmand so we can address any questions you may have.
Thank you so much, Dr. Park. I think I was muted there for a bit. So what I wanted to do is just now address your questions, and we're going to sort of take turns in answering all your questions and concerns. So the first question comes to us from one of you, and it states that I'm 55 years of age and want to find out if I have any viable eggs. I've not gotten my period for over 2 years. What are my chances? So typically, if you have not had your period for over 6 months, and at age 55, most probably you've gone through menopause, which means that there are no longer any, unfortunately, viable eggs in the ovaries. Thus, the only option available to you for a pregnancy would be using donor eggs. Having said that, at 55, there are some concerns that we have in regards to some complications with the pregnancy. So this is something we need to discuss with you prior to moving forward with an IVF cycle of using donor eggs.
Let's see. I see a question. We're just going to take kind of questions as we go. I just saw one that popped up on how IVF differs from InVicell. And so happy to talk about that. So right before the world turned upside down, we were about to launch InVicell. So InVicell, so we typically talk about 2 treatment options like Dr. Park has described, and those are our 2 categories of fertility treatment. There's a third option, which we hope to be able to resume our launch after this COVID-19 situation is better under control, called InVicell. InVicell relates to what's called intravaginal culture of embryos. So for InVicell, what you're doing is the woman's body is actually acting as the incubator. So just like Dr. Park described, there are some injectable medications which are taken typically at lower dosages, and in less amounts, there's less ultrasounds, less injections, less monitoring. So it's typically less time consuming, less invasive, less costly. There is an egg retrieval done under anesthesia. Then here's where it differs. Where it differs is then the egg and sperm are put together into a plastic device in the size of a champagne cork. And then that device is placed into a woman's vagina. And the vagina acts as the incubator. So we're not using our incubators in the lab. We're not doing ICSI when we inject one sperm into each egg. We're not doing genetic testing of embryos. So it's really more of a minimalist approach in which fertilization occurs in vivo, so in a woman's body in the vagina, because she is the incubator for that 5-day period of time. The woman comes back to us in the clinic. We remove the InVicell device from the vagina, retrieve the embryo, and then transfer the embryo back to the uterus. So it's similar in the sense that we are bypassing the fallopian tubes. So for people who, for example, have blocked fallopian tubes, or for a female-female couple who is interested potentially in one partner carrying the embryos for a period of time, this could be a good option. So we would be happy to talk further about whether or not that would be an appropriate next step for some of you if you're interested. So that will be coming soon. Stay tuned, San Diego Fertility Center, and we are planning on offering that in the coming months, but we're not offering it at present.
Okay, I will read the next question, which says, we've done our fertility treatment and all the tests seem to come back normal. It's very frustrating. How do we know what's the right treatment for us? You know, that's a great question. And I will say there's no right or wrong answer. There's so many factors to take into consideration. So one of the biggest factors is age, right? So let's say you did all your testing and you're 32 and all the tests are normal, and while you wanted a baby, it wasn't yesterday, you're willing to be patient, then I would advocate for conservative treatment like IUI. But let's say you're 39 or 40 and all your tests are normal. Maybe you haven't tried anything. I would still advocate, maybe give a conservative treatment a try, but I wouldn't suggest it for as long as that of a 32-year-old. Maybe max 3 cycles of IUI, or maybe just 1 or 2, but then you move on to IVF. And the question is, but why? Why is that different? Because a 39-year-old has very different egg quality from a 32-year-old. And what happens is as women get older, what does it mean that your egg starts to degrade in quality? It means that slide I showed about the PGT, where you have a number of chromosomes, it means that when the egg and the sperm meet, the egg is more likely than not to have the incorrect number of chromosomes the older you are. Meaning there's a higher likelihood that we can make embryos for you, but they may not be chromosomally normal. And that probability gets higher and higher as you get older. For that reason, you want to find the fastest way to get pregnant, which would then be IVF. So that doesn't mean you can't try the more conservative treatments, but how aggressive you are and how quickly you become aggressive will really depend on a multitude of factors. I mean, obviously, if your tests are abnormal, that's a little bit clearer, but if your tests are normal, one of the biggest factors to take into consideration really is age.
Thank you. The next question is about how does being overweight impact success with IVF treatment? Well, there have been some good studies that have been done. We use an index called the body mass index in order to assess weight as a function of height. And that gives an idea about the potential risk of complications during pregnancy, as well as the possibility of implantation and success during IVF. Based on some research studies that were published in Spain, those particular studies showed that when the body mass index increased beyond 30, there was a decrease in implantation rates and pregnancy outcome with in vitro fertilization. So we know that increasing weight can potentially have a negative impact on the success of IVF. And we also know that increasing weight, especially when the body mass index is above 30, can also increase the risks of gestational diabetes, high blood pressure, and other complications during pregnancy. So we want to support you in your journey to becoming as healthy as possible. So we work with nutritionists. We also have some background information on nutrition and health because we feel that nutrition is really important in terms of keeping the pregnancy healthy, your future children, and also making sure that you are healthy long-term for your children. So this is something that we can certainly support you and discuss with you. And also we recommend consultation with a nutritionist as well. So we will hold your hand throughout this whole journey until you become parents.
So next question, I see there's a question that says, are you willing to implant twins through regular IVF for a 40-year-old woman? So this is a really important question, and the question of multiples as it relates to IVF comes up a lot. And one of our philosophies at San Diego Fertility Center is really individualized treatment planning. So there are many clinics in San Diego and abroad that will refuse to transfer more than one embryo. And we really feel strongly that that decision has to be made between the patient and their physician, because the decision to transfer 1 or 2 embryos can be a complex one based on embryo quality, based on whether genetic testing was done, like PGT, like Dr. Park was mentioning, and also the health of the recipient. So there's many things to consider, but Really, we don't see it as a black and white decision. We do advocate for single embryo transfer because our whole goal is healthy mom, healthy baby. So we really want to help you have a healthy, uncomplicated pregnancy. And the best way to do that is one healthy baby at a time. We want to help you have as many babies as you want, but ideally one at a time. So we're here to help support you in accomplishing that. We will advocate for single embryo transfer. We do also respect patient autonomy, and we understand that these are your embryos. So that treatment decision is really one that needs to be made between you and your physician, and we're here to help you through that.
Okay, next question. How can I improve my egg quality? Oh, that's such a common question we get, and that's a great question. So, number one, unlike men, they make new sperm all the time. Women do not make new eggs. You're born with your lifetime egg supply. And then when we run out, which is usually the age of 50, 51 in the United States, is when women go through menopause. And it's a common misconception. People think, okay, because you're born with about 1 million eggs. And people think, so I just lose 1 egg every month. Actually, you don't. There's a cohort of eggs, the antral follicles that Dr. Friedman mentioned. You have these antral follicles. And every month, if you don't ovulate them, they dissolve. So because you lose multiple eggs every month, you will run out of eggs by the time you're 50, 51. So what can you do to slow this down? Well, number one is if you're smoking, you should just stop smoking, because smoking will accelerate the pace at which you lose your eggs. But some of the things in your past cannot be helped. So for example, having had ovarian surgery, like a cyst removed, or having had chemotherapy, all of that will decrease your egg count. But let's just say none of that is in your history. And you're 37 and you did your egg test and it came out so-so, okay? Well, the honest truth is there is no magic pill out there that will definitively improve your egg count, but there are things that you can consider. So many people talk about supplements, and there are many, many supplements out there. The two that are probably the most popular is DHEA and CoQ10. And my recommendation would be, there's a really good book out there called It All Starts with an Egg. And the author of the book has done incredible, she's not a scientist, she's done incredible research from her own personal journey and has made a book to help other women figure out what supplements that may or may not be useful. So I think taking supplements is a great idea. Another option is perhaps seeing an acupuncturist. And not everybody's into holistic medicine, and every person has their own opinion, but it may be a good idea to at least consult with them, just to ask them, well, what do you think? Because through acupuncture, and usually it's coupled with herbs, it's a very non-Western way to try to tackle the egg issue problem. Okay, but a lot of these methods may not necessarily increase the quantity of your eggs, but they may. But the hope is that perhaps you can alter the quality of your eggs. But none of them have been proven to definitively make a difference. And I'll tell you, in my years, I have seen cases where I didn't see a difference, but I have seen cases where I did see a difference. And I wasn't sure if it's just the supplements and or the acupuncture, but I really feel that if you want to put your best effort forward, I would consider as many possible options as possible.
So next question is, can you review the cost and timeline for a gay couple? And the follow-up question, and how long does the initial sperm analysis take? So typically for a gay couple, we want to make sure that you are matched with a healthy egg donor. And we actually are fortunate to have our own egg donor database with a database of donors that have all been pre-screened for genetic health, for egg quality analysis, psychological health. All those health parameters have been screened for in the egg donor database. Also, we want to make sure that we find a gestational surrogate for you, someone who's healthy, between 24 and 42, previous pregnancy without any complications. So it's a set of very strict criteria that we have, and we do screening on your gestational surrogate in order to make sure she's healthy and that she has the chance of achieving a very healthy pregnancy. And typically from the time when we do a consultation to the time when you have your baby is roughly around, on average, about 14 to 18 months. And again, there are many steps. We usually divide them into 3 steps. One is the sperm. We initially do a sperm analysis and then a sperm freeze. The sperm analysis is an analysis that's done where we look at count, motility, morphology, which is the shape of the sperm. The second step is choosing your egg donor, and then creation of your embryos through IVF. And then the third step is finding an ideal gestational carrier, gestational surrogate, who's going to be able to help you achieve your goal of parenthood. And again, during our consultation, we will review all the steps with you on this journey to parenthood. In regards to costs, it doesn't really vary that much significantly from center to center, because that was one of your questions. But we have a great financial team here at your disposal, and they will sit down with you and review all the costs associated with this particular journey with you.
So I see a question that says, I have already completed 1 IVF cycle and the pregnancy was an ectopic. What is the likelihood that this will occur again? Well, first of all, I just want to say how sorry I am that you went through that. We know that there's so much that goes into an IVF cycle, not just financially, but emotionally and physically too. So we're all very sorry that that was the outcome. Fortunately, the chance of an ectopic pregnancy with IVF is very low. So it's, again, I'm so sorry that that occurred with you. We know that with a frozen embryo transfer, the risk of an ectopic pregnancy is actually less than 1%. So at San Diego Fertility Center, we really focus on frozen embryo transfers as compared to fresh. And so when we're doing a frozen embryo transfer, meaning the embryos were previously created and frozen, and the day of the transfer we're thawing an embryo, fortunately, the chance of an ectopic is very low. So given that that happened in the past, I would not think that it would be likely at all. Fortunately, it would be very unlikely that that were to happen again.
Next question. My sister did treatment at your center and she got pregnant. I've been doing treatment in my city, but I don't live in San Diego. My sister's saying that I should come to your clinic for treatment. What do you think? Why? I don't know where you did treatment at your clinic. There are a lot of great fertility centers around the country. I will say, and I'm not being biased, I mean, I used to practice in New York at Columbia, which was a great center, but I can honestly say that San Diego Fertility Center has an amazing IVF lab. And again, not knowing where you did your treatment, I don't know about the quality of the lab at your center. But I'm not trying to sell a pipe dream. I think that you need to go to a center that you feel comfortable at. But I do know that our center has a high quality lab, which does make a huge difference. So if you choose to do treatment at our center, but you don't live here, which by the way is very common, we have a lot of patients who will come to us from a different city because a family member did treatment here or a sister did treatment here, or they want to use our egg donors, etc. The way it would work if you're using your own eggs is we would first do a Zoom or Skype or telephone consultation and get your medical history. And if you have a male partner, that as well. Once we figure out medically where everybody stands, then we can come up with a treatment plan. And let's say the plan is you want to do IVF with your own eggs, your partner's sperm would transfer into you. So you would then start your treatment in the city you live in. But we would manage you from here, meaning that we would tell you, okay, on this day, please go to your local fertility clinic and have the ultrasound done and the blood work. But we will then interpret the results. And based on the results, we will then tell you how to adjust the dose of your IVF medication, how long to take it for, and when to go back. And generally, after about 1 week, is usually when we want you to come to San Diego, because we want you to finish your tail end of your treatment here. And in this case, you could stay with your sister. We would do the retrieval here. Your partner hopefully can come with you and he'd give us sperm that day. If we know he can't be here, he needs to come to our center at some point before the treatment to give us sperm that will freeze. For the day of your harvest, we would fertilize. And generally, we would advise that you stay and recover in San Diego, maybe for a couple of days. It really depends on how many eggs we get. Because if we get 2 eggs, you can go back the next day. If we get 20 eggs, you may need 3 or 4 days to recover. But you recover for a few days and you can go back to your city. but the day that we did your surgery here is when we fertilize, we incubate for 5 days, and then we let you know how many blastocysts there are. And if you choose to do PGT, we'll biopsy, we give you those PGT results. Once we have that, we then again do another phone, Skype, or Zoom to go over the outcome. And we can then plan for your transfer. And similar to the egg retrieval, the transfer is the same. You prepare where you live, we manage you from here. But then you fly here for the transfer. Usually fly the day before you transfer. We do your transfer, for which there's no anesthesia because it's usually painless. And then the next day you fly back. And then wherever you live, you do a pregnancy test about 2 weeks later to find out if you're pregnant or not. So it's very doable, and we do it all the time. It just requires just a little bit of synchronizing with your local clinic, but it's very doable. But at the end of the day, you have to pick the clinic that just feels right for you. Whether it is us or not, it just has to feel like you have to be comfortable you're in the right hands.
The next question is the following. I've been diagnosed with PCOS and don't ovulate. We have tried IUI once with Clomid and the ovulation-inducing injection, but my follicles did not get to a large enough size. Is IVF our best option when I don't ovulate? Well, actually, there